Today, we're going to be talking about a chronic inflammatory disorder that primarily affects the linings of the joints. For this 32-year-old professional ballerina, the disease caused a collection of painful symptoms that threatened to end her career. Mila came in to see her primary care doctor with a 6-week history of fatigue and joint pain, which began in her ankles and then started to affect her knees. Over the last couple of weeks, she had also noted some stiffness in her fingers, and she told her doctor that she'd been feeling most stiff in the mornings, but usually felt better after a warm bath and after getting up and moving for a while. She had been rehearsing longer hours than usual, learning a new solo part for the company's upcoming performance season, so she initially thought her stiffness was related to overexertion. She also worried that at the age of 32, the fatigue she was feeling might be a sign that her professional ballet career was slowly coming to an end. But then she began to notice that her joints also felt unusually warm and tender, unlike any activity-related soreness that she had experienced in the past. She decided to see her doctor, who quickly recognized the classic signs of inflammation, historically called calor, dolor, rubor, and tumor, referring to the warmth, pain, redness, and swelling that typically accompany inflammation. Mila's physician suspected an inflammatory disorder, but realized that her fatigue and other symptoms could also be explained by other types of illness, including an infection or a malignancy. He decided that these were less likely when Mila denied any constitutional symptoms like fever, night sweats, weight loss, or changes in appetite. To explore potential cardiac origins for Mila's symptoms, he also asked about chest pain and shortness of breath, but she denied any other symptoms beyond what she had described when she came to the office. She didn't remember any recent infections, had no skin rashes, exposures to sick contacts, or recent travel. The only pertinent findings uncovered during the family history were that Mila's paternal grandmother had suffered from systemic lupus erythematosus, or SLE, and had died in her late 30s. Mila also thinks that her French grandmother on her mother's side might have suffered from some kind of arthritis. The fact that Mila's symptoms had been going on for more than a month, involved multiple joints, and were not associated with fever caused her physician to suspect a potential autoimmune etiology underlying the ballerina's symptoms. On physical exam, Mila's joints were visibly swollen with decreased range of motion, slight erythema, and warmth to the touch. Her physical exam was otherwise normal, so the physician decided to order some blood tests, including a CBC with differential that revealed elevated white blood cells, in particular elevated neutrophils, as well as an erythrocyte sedimentation rate, a C-reactive protein test, and tests for rheumatoid factor and an anti-nuclear antibody test. The ESR and the CRP were both elevated, suggesting systemic inflammation. The RF, a test that's primarily used to help diagnose rheumatoid arthritis, was strongly positive, while Mila's ANA was negative. Mila's physician immediately started her on an anti-inflammatory medication and referred her to a rheumatologist who saw Mila quickly. He ordered x-rays and also aspirated some synovial fluid from the joint space of Mila's right knee, which was slightly more swollen than the left. Mila's x-rays revealed increased fluid in the knee joints consistent with an effusion, as well as some soft tissue swelling, but no signs of bony erosions on the articular surfaces. This is a finding that is sometimes seen in the later stages of inflammatory diseases involving the joints. Mila's synovial fluid contained no crystals, but had many neutrophils and some B and T lymphocytes. These lab results, together with the history and physical exam findings, suggested a diagnosis of rheumatoid arthritis, a systemic inflammatory disorder that results when the immune system inappropriately attacks host tissues, especially the tissues of the joints. In patients with a genetic predisposition for developing RA, it's hypothesized that an insult like an infection or trauma may lead to abnormal modification of proteins by cells in the synovium of the joint. One protein modification that's been strongly implicated in RA is citrullination. Modified proteins are detected as foreign by the immune system, causing it to inappropriately deploy a cascade of immune defenses into the joint. These include the influx of immune cells and the release of inflammatory cytokines, including tumor necrosis factor, interleukin-1, and others that induce additional inflammatory responses. The cytokines increase blood flow to the joint and act like growth factors, leading to cell proliferation and hypertrophy of the synoviocytes that make up the synovial membrane. These synoviocytes make additional cytokines and secrete proteases that can erode the cartilage and the bony surfaces of the joint. Together, the infiltrating white blood cells, B cells, T cells, and neutrophils, and the hypertrophic synovial membrane form a pannus within the joint space. The result is chronic joint inflammation that can eventually lead to irreversible damage to cartilage and bone. Luckily, in Mila's case, her condition was diagnosed and treated early. She continued the anti-inflammatory medication she'd been taking, and she was prescribed a corticosteroid and a TNF inhibitor, a drug designed to bind to and neutralize tumor necrosis factor. In patients with tuberculosis, TNF plays a critical role in controlling mycobacteria and containing them in granulomas. So Mila's rheumatologist ordered a PPD and a chest x-ray to make sure that she didn't have latent pulmonary tuberculosis before starting the drug, since TNF inhibitors are known to cause a reactivation of latent TB. Once the TB tests came back negative, the medication was started, and Mila noticed a dramatic improvement in both her fatigue and joint pain. Within a month, she was able to return to her full training and performance schedule. Mila's physician told her that in most cases, patients with RA require long-term treatment with TNF inhibitors and anti-inflammatory medications to control their symptoms and prevent permanent joint damage. Mila continued to do well on these medications.